Welcome to the CPC On Demand Learning Series. The topic for this presentation is the motivation for change. I'm Dr. Russell Cole, Medical Director for TMF Health Quality Institute. Today we will hear from Dr. Mark Couch, President of Pri-Med Physicians. Pri-Med Physicians is an independent multi-specialty group of practices in the Dayton, Ohio metropolitan area. Pri-Med has 17 locations across the Miami Valley, representing 64 physicians. Dr. Couch practices family medicine at Pri-Med's Vandalia Family Practice. His practice has 2 physicians and 12 employees.
Hello, I'm Dr. Mark Couch. At Pri-Med Physicians, we've been working on changing the way we practice medicine for many years. You may remember a study a few years ago where it was found that if a physician were to do all of the care that was needed at 100% of the evidence-based standard, it was more than twice the time a full-time family physician could work. There's no way using a model with an individual physician responsible for all of the work could accomplish all of the necessary care on their own. We realized that we needed to push some of the work down to other staff members who could work at the top of their license and capabilities to complete some of these tasks. Physicians can then direct the resources and work together to create processes as well as assure the team can provide a better system of care. This frees up the physician to ensure that these things are completed, not having to do them all. We distributed the roles and their responsibilities based upon training and proximity to the steps in the process. One example that uses team members working at the top of their capabilities is the way we accomplish getting patients scheduled for their diabetic eye exams. Our front reception staff is responsible for this activity. They ask all patients with diabetes at the check-in if they have had their eye exam. If the patient says yes, they record and verify the date of the medical record. If they respond no, they ask if they can help schedule that examination. If the patient agrees, they help them schedule the exam. Only if the patient says no, that they do not want to schedule it, is where the physician comes in. We discuss this with the patient in the examination room and record the informed decision. There are times when you need to use data to convince physicians and other team members that this approach works. If you show them that a physician alone completes this task only 60% of the time, and when it's done with the front reception person, the task is completed over 90% of the time. When that improvement is noted, physicians are more likely to hand the task off to someone who can help them achieve higher performance. We understand that using an effective process can have an impact on the outcomes. Hypertension care is a good example where process is important. A few years ago, we looked at patients who had their blood pressure in control at any given moment. At the 2005 beginning of the project, only 45% of the patients were in control. We began to measure whether a patient's blood pressure was in control at all visits. And from there, for the next few years, we moved from smaller sample size to complete accounting of every patient at every visit, measuring the individual practice performance and now having that in front of the entire group to share information, linking the performance to compensation for the physicians, adding technology such as impedance cardiography, and linking this process with other processes were all different steps that impacted performance. Today, we are at 90% control for all of our diabetic and hypertensive patients who come into the office at any given visit. Our change process for hypertension control involves looking at the data and changing the process. To begin, you put your stake in the ground and say everyone must follow that process. With a clear expectation and encouragement, staff will try the process and create feedback. Then additional changes are made and performance is measured so that it works for everyone. In the end, we create better results. We believe that everyone is needed to be a leader. We get staff engaged. They are then accountable to talk to each other about the change process. We review the process frequently. We have monthly data reports on all Pri-Med offices. Managers review the data with both physicians and staff, and then post it in the break room for all staff to review so that they can see where their office stands. The staff reviews this closely and works hard to improve. It can actually be quite competitive between the offices. We are now at the point where all of our offices are doing well on these measures. We are part of a collaborative here in Ohio that shares information with other like-minded regional provider offices. We look at the various clinical quality measures to see how we are doing and how everyone else is doing. Sharing with the other offices increases communication between the offices, improves the flow of information, and helps to understand best practices. This helps us change in a way that is most meaningful and beneficial to all. It helps us improve and change care throughout our entire region. One of the greatest challenges to overcome is finding the time to do this work. Today we find ourselves following more and more processes as we work to improve, yet we must doggedly stick to these processes and follow them through to make the changes that are necessary. All of this takes time. Another area to keep in mind is the motivation of our physicians. We know that physician burnout is a crisis in the United States today. We are going through many changes at once. We must work together to get the help of other people, to look at opportunities to simplify the lives of the physicians. Sometimes the work does not seem to have meaning to them. At Pri-Med, we went on a retreat and went through Simon Sinek's book, Start With Why. It challenged us to look at what we believe and how does the work that we do fit into this system of beliefs. How do you keep a person energized to stick to the course? You must first make work meaningful and change the context around why we do what we do. We recognize that staff may be overwhelmed with the change we are undertaking as well. This is a human condition about change, not an individual problem. It is important for the staff to see that the doctors are doing something with the change also. One thing we do when staff is overwhelmed is we buy ice cream or pizza for the office. Yes, it's a Band-Aid, but it recognizes that we appreciate the hard work that they are doing for us. Physician and staff meetings are not about what we are doing wrong. We start each meeting with the positive, giving praise and calling people out for the good work that they do and special recognition for their accomplishment. At Pri-Med Physicians, we are building a culture of change together as a much larger group. Just seeing what we've accomplished helps. We start with seeing the need for change. This may be seen as a burning platform. The constituents must get to the point where they recognize that need for change and then decide on the actions to take. They then start to measure and look for results. We then need to hold people accountable and be certain people are supporting each other and that you get alignment towards your new goals. You must culturally recognize that if your organization agrees that you want to accomplish these new things, that not all people will align with it. We did all that we could to help ensure alignment, but some people opt out. That's okay for them to find a better place for their needs elsewhere. We have learned that to maintain the momentum of change, you must continue to grow. This is an evolutionary process that does not stop. You must keep going. Help people increase their competencies. It increases their reach across the medical neighborhood. For example, I recently met with another system CEO in the Dayton community. We looked at working together to teach their system what we have learned and work together to look at the health of the whole population in this entire region. We are also looking at other options in our change journey, such as bringing in nurse practitioners to help our processes in the future. All of our decisions are based on data. We must look at how we add physician extenders in a way that best helps our team. We look at how the new processes might help performance using clear and objective data. Remember to keep the communication channels open, both in the office and in the collaborative community. Other people are in the same situation as you, and there are huge benefits with sharing ideas.
We hope you found this presentation insightful and useful for your practice. To wrap up the presentation, let's take a quick look at some of the key themes Dr. Couch raised today. Most anyone in primary care recognizes the almost overwhelming time demands to be effective in our specialty. These demands require a team approach where each member of the team works entirely at the top of their license, and it's important to recognize that we must have true teaming and not simply a division of labor. While top-up licensure will allow labor to be distributed, making sure that the entire team is involved in the analysis and data aspects of quality improvement is really key to getting their buy-in. In my years of quality improvement, I've never ceased to be amazed by the impact of a simple dozen of donuts or of a pizza to facilitate meetings with staff that allow you to really delve into the heart of the issues and obtain staff buy-in to projects. In my experience, most physicians are truly amazed when they see their population data. We frequently only know the results for the patients we actually are seeing in the office, and thus have a skewed view of how our performance may actually be across the entire population. When faced with the data for our entire population, it can sometimes be disheartening and almost always is surprising for physicians. For this reason, peer sharing tends to be a very important aspect of quality improvement. One of the things we recognize is that there's not a cookie-cutter approach to medicine. Each practice has its own idiosyncrasies that allow many items to be shared, but that requires a small degree of customization to be most effective. This is most effectively accomplished through peer sharing, where you can see both the large project and the small iterations and adaptations that were necessary to make it work at the individual primary care office level. Physician compensation is an area that's often overlooked as it relates to quality improvement. While value-based purchasing may be a discussion at the national level, frequently this quality-based payment doesn't drive to the actual physician level. I think that's a very important aspect of the discussion, and one certainly worth looking into further. One of the most difficult things for a medical practice to approach is when a team member is not performing at the level required for the team to be successful, whether this is the result of training or competency. It's important to recognize that a team is made up of individual performers, and that sometimes a member of the team is not able to perform or develop to the level required for the team to be effective. In these cases, I think recognizing that it's not only in the team's, but also in the person's best interest to find a team where they fit better is a really useful construct. Thank you for watching The Motivation for Change. We hope you found this presentation useful and will take the time to watch other videos in this on-demand series.